There are 46 million Americans who are uninsured in this country. How do you see that affecting cancer rates?
People who are uninsured are treated late in our society for very distinct reasons. First of all, they can't get into the system until it's too late, and often they don't even come or try to get in because they know they can't get through the system. So we know from statistics that when you're uninsured, you have a 10 to 15% lower 5-year survival, just on that factor alone. And so I think that I can't accept the point in America that there are 47 million uninsured American people who can't get in early enough to be saved. And in addition, another 35 million American people are underinsured, in addition to the 46 or 47 million, who will get tested when they have a complicated disease to the point that they cannot pay for their treatment. And either the number 2 or 1 cause of bankruptcy in America today is failure to pay medical bills. So the question then, Katie, becomes this: is it really civilized to have a population of people, about 100 million of whom, a third of the nation, are either uninsured, underinsured, or poor mixed together, who get in late and who die? The question becomes, should poverty be an offense which is punishable by death? And I believe that when people get in late because they're poor and they die, we're more or less saying, you die.
Your goal coming here was to level the playing field.
Yes.
For poor people and cancer.
Yes.
Did it seem insurmountable in some ways?
It's been a real struggle for me to try to accomplish what I set out to accomplish, even as a young surgeon who in the late 1960s saw the problem and became frustrated, to be honest with you, very frustrated. I come to work, and what I'm trained to do is not the real answer. And that drove me to try to understand what was driving it: poverty, the main issue, but also culture and behavior mixed in. And so I set out to try to change this at one hospital in the beginning. That's all I knew to do. And I began to think of things to do. And the first thing that I did, Katie, was in 1979. I was, through resources I was able to obtain from the governor of the state, Hugh Carey at that point, gave money to me to use in Harlem to set up free screening for breast cancer. I did that. That same year, I set up a free screening clinic within Harlem Hospital. And I was dealing mainly with breast cancer at that time, and still did for most of my career. And so the first thing I tried to do was to assure that people who were poor and uninsured could be screened for cancer through the mammogram, through the physical exam, at 2 different sites. That helped. But then that uncovered another set of problems. So now we could do the mammogram on these women, and we got them to come in for that to a certain extent. But then some of them had findings that needed to have biopsy and treatment. So the test itself had done some good, but it wasn't the answer if they had if they needed a biopsy and they were uninsured. And so I began to look at that issue. And along with the national hearings that I held in 1989, came to the conclusion that a new kind of program needs to be created for people who have screening or findings, but need to be navigated through the healthcare system to resolution, including treatment. And so that is how the navigation idea came into effect.
The Patient Navigation Program really isn't simply getting people screened, although that's the first step. But it doesn't stop there. It's navigating through the system and helping them treat whatever the screening has found.
Yes. In fact, the concept that I developed in 1990 at Harlem Hospital came on the back of already offering free screening to the population. And I knew that, see, having a test for something is not enough. And we teach America, get a mammogram, get a colonoscopy, get whatever. And we believe that should be done.
Has it been gratifying to see your program serve as a prototype for so many others in this country?
I am absolutely thrilled with the point that, from my own beginnings, which are meager, first of all, they have the opportunity to be educated to a high level, and that's based on a lot of things that I've already discussed with you about my family driving me to higher levels. But to have the opportunity to become a first-class cancer surgeon and to then come to a community where people were suffering at a high rate, and then through decades of work have discovered some things that can substantially help those people to get in for early diagnosis. Education is very important. Educate people that they need to come in for a test. But I learned early, it's not enough to tell people they need to get a test if they can't get it. You have to make sure they can get it.